Imagine for a second taking this, life-saving medication that literally destroys your fertility and forces your body into menopause before you even hit 40.
Right, yeah.
But then imagine discovering that this totally devastating side effect, the very thing that just ruined your hormonal health, might actually be the biological shield keeping you alive. Welcome to the incredibly murky, paradoxical world of autoimmune disease.
Yeah, I mean, it is the absolute definition of diagnostic muddy waters, especially when we examine systemic lupus erythematosus, or, SLE.
Yeah.
Because in the clinical landscape, these autoimmune diseases, they really rarely travel alone.
Yeah.
They operate in these tight networks.
Yeah.
And our focus today is understanding not just the fact that these networks exist, but the underlying mechanisms. Like, how do these rogue immune responses compound one another to create this cascading crisis within a single patient?
Okay, let's unpack this for you. Welcome to today's deep dive. Whether you are, say, a clinician prepping for a really complex case review, or a patient navigating a daunting new reality, or just someone insanely curious about how the human body works and, sometimes how it systematically turns on itself, you are in the right place.
Absolutely.
Today, our mission is to comb through this massive stack of clinical sources to understand the complex web of SLE. We aren't just looking at lupus in isolation here. I like to think of it this way. Lupus, it isn't a solo artist. It's like a lead singer that brings along a whole band of clinical complications. And today, you and I are going to meet the band.
I love that analogy because the clinical reality is that you just cannot treat the lead singer while ignoring the rest of the stage, right?
Yeah.
To understand the true reach of lupus, we really have to start by looking at its most frequent collaborator.
Right.
We're talking about a secondary condition that fundamentally attacks the body's moisture producers. When this biological desertification happens alongside SLE, it is clinically referred to as secondary Sjogren's disease.
Which is pronounced S-O-W grins, by the way, for anyone reading it on a chart for the first time and thinking, how do I say that?
Yeah, exactly.
The numbers in our sources are actually striking. It is the UK's second most common autoimmune rheumatic disease. 90% of sufferers are women, usually hitting around a mean age of 50. But despite that prevalence, it flies completely under the radar.
It really does, and largely because of how the symptoms are conventionally described. When you hear someone say dry eyes or dry mouth, it just sounds like a mild inconvenience, like, oh, just drink some water.
Right. Yeah, exactly.
But the reality is this profound systemic attack. The immune system is actively targeting and infiltrating the secretory glands. So the lacrimal glands producing tears, the salivary glands, and even the mucosal glands in the gastrointestinal tract and vagina.
Wow.
The inflammation doesn't just reduce moisture, it effectively destroys the architecture of the glands themselves.
So it's not just, needing extra lip balm or some eye drops. We are talking about debilitating physical and mental fatigue. The sources highlight severe brain fog, the inability to even swallow dry food without choking, and massive drops in health-related quality of life.
Yeah, it's severe.
Like, the data shows the quality of life drop for a Sjogren's patient is entirely on par with someone suffering from rheumatoid arthritis or severe lupus.
What's fascinating here is the molecular overlap driving this destruction. We're really looking at the shared autoantibody profile. In this clinical web, we see a high prevalence of anti-SSA, which is also known as Rho, and anti-SSB, or LOT, antibodies.
Okay, so wait, let me ask a clarifying question for the listener here. Are these the exact same antibodies in both diseases?
Basically, yes. Roughly 30% of lupus patients carry these specific antibodies, but they are present in like 70 to 80% of Sjogren's patients.
Wow.
Yeah, and these antibodies target specific ribonucleoproteins inside the cells, essentially triggering this cell death cascade right within the moisture-producing tissues.
So if you're a clinician listening to this, or, a patient sitting in an exam room with debilitating dry eyes and overwhelming fatigue, how do you even pull those apart? Like, is that the lupus flaring up, or is it the Sjogren's taking over?
It's a really tough clinical distinction.
Let's look at it like a car with a glitching central computer, right? The overall glitch, the main system failure, is the lupus. It's affecting the whole vehicle. But this specific line of bad code decides to specifically target and shut off the windshield wipers and the oil pump. The car is technically still running, but without those vital fluids, the internal friction is going to destroy the engine really fast.
The friction is the perfect way to look at it, honestly, because the tissue damage is just severe. I mean, without tears, the eyelid essentially acts like sandpaper over the eye.
Oh, that sounds awful.
It is. The sources detail severe complications like corneal ulcerations, which can permanently threaten vision. And saliva, it isn't just water, you know. It
Well,
contains crucial enzymes and antimicrobial proteins.
hmm
Take that away, and patients face rampant aggressive dental decay and failing teeth. And moving down the digestive tract, when the large bowel loses its mucosal moisture, things stop moving smoothly. Patients develop severe, painful symptoms that perfectly mimic irritable bowel syndrome.
It fundamentally changes how you view saliva and tears. They aren't just fluids, they are literally the frontline defense mechanisms for our most vulnerable tissues. And this rogue immune response just flips the switch off. So lupus can dry up the body's local reservoirs. But the real danger happens when those same rogue immune complexes infiltrate the main supply lines, the bloodstream itself.
Exactly. And that brings us directly to lupus vasculitis. Vasculitis is, simply put, inflammation of the blood vessels. It's a severe complication affecting anywhere from 11 to 36% of lupus patients. And the mechanism behind it is, well, it's a perfect example of collateral damage.
Here's where it gets really interesting, because this isn't just a random attack. We're talking about those immune complexes, again, autoantibodies bound to your own self-antigens. Let's use a plumbing analogy, but take it a step further.
Sure.
If the blood vessels are the pipes of your house, these immune complexes are like a hard, toxic mineral buildup floating through the water and slowly, adhering to the inside walls of the pipes.
Right. And the buildup itself is problematic, definitely. But it's the immune system's disproportionate response that causes the structural failure. White blood cells, specifically neutrophils, they spot these complexes stuck to the vessel walls and just rush in to neutralize them.
But they don't act like a plumber gently clearing a clog, right? It's more like the immune system spots a spider in the kitchen and decides to set off a live grenade to kill it.
That is painfully accurate. The grenade being the destructive enzymes the white blood cells release. They degranulate right there on the vessel wall. This massive inflammatory cascade literally burns through the endothelial lining of the blood vessel.
Wow.
So the vessel walls can weaken and burst, causing hemorrhage. Or they can become inflamed, thicken, and drastically narrow, completely cutting off blood supply to the tissues downstream.
And according to the sources, the clinical presentation is entirely dictated by the caliber of the pipe. Like, size really matters in vasculitis.
It does. Small vessel vasculitis is the most frequently seen in lupus. We are talking about the tiny capillaries in the skin, the peripheral nerves, and inside the organs.
When you say the skin, this is what the sources refer to as palpable purpura, right? To translate the clinical term, we aren't just talking about a mild, flat rash.
No, not at all.
These are raised, distinct red or purple spots because the tiny capillaries have literally burst, leaking blood directly into the surrounding skin tissue.
Exactly. And when that small vessel destruction happens in the nerves of the feet, patients experience numbness, tingling, or severe neuropathic pain. But the most critical threat is when this small vessel grenade goes off in the kidneys.
Right, the kidneys.
It triggers glomerulonephritis. The delicate filtering structures of the kidneys are shredded, spilling blood and massive amounts of protein into the urine, rapidly leading to end-stage kidney failure if it's left unchecked.
So what happens when the immune system targets the larger supply lines?
Well, medium vessel vasculitis is rarer in lupus, but highly dramatic. These are the arteries supplying the arms, legs, intestines, and even the heart and brain. A patient with this presents as acutely, severely ill, often with high systemic fevers and agonizing pain in the affected organs due to the sudden lack of oxygenated blood.
And what about the really big vessels?
Interestingly, large vessel vasculitis, which affects the aorta and the major arterial branches, is practically never associated with lupus. If a lupus patient has inflammation of the aorta, clinicians must look for an entirely independent disease like giant cell arteritis.
Okay, so the lupus grenade only targets the small to medium pipes, but what pulls the pin? Like, what actually triggers this specific vascular attack?
Usually, uncontrolled aggressive lupus flares are the most common trigger. However, the sources highlight a deeply frustrating secondary trigger, which is the very medications patients take.
Oh, wow.
Yeah, certain antibiotics, blood pressure medications, and notably, propylthiouracil, a drug used for hyperthyroidism, can induce vasculitis.
But how does a drug meant to fix a thyroid issue trick the immune system into attacking a blood vessel? That seems wild.
The drug molecules can sometimes act as happens. They bind to the proteins on the walls of the blood vessels, altering their shape just enough that the immune system no longer recognizes them as self. It suddenly sees the blood vessel as a foreign invader and launches an attack.
Wow. And if we connect this to the bigger picture, why should you, as the listener, care so deeply about this specific vascular complication?
Because a compromised vascular system transforms lupus from a disease of chronic daily misery into an acute catastrophic threat. When you have narrowed, inflamed, and weakened vessel walls, the risk for massive aneurysms, sudden heart attacks, and debilitating strokes just skyrocket.
In pregnancy, right?
Exactly. For a pregnant lupus patient, this vascular damage severely elevates the risk of preeclampsia, threatening both the mother and the fetus.
It is terrifying. Which honestly brings us to what I found to be the most agonizing reality of this entire deep dive. We just established that medications can inadvertently trigger vasculitis. But that leads us straight into the most paradoxical, double-edged sword of the lupus clinical web, the heavy toll of the rescue treatments themselves.
Yeah, it's a grim reality. When a patient is facing organ failure, when the kidneys are being destroyed by lupus nephritis or the brain is under attack, the medical interventions required to save their life are incredibly aggressive, and they leave permanent scars on other biological systems. The most devastating of these is premature ovarian insufficiency, or POI.
Premature ovarian failure. This is complete menopause occurring before the age of 40. Now, the baseline data shows that SLE patients tend to experience menopause a bit earlier than healthy controls anyway, but the rates of POI induced by lupus treatments are just staggering.
They are. A systematic review we examined placed the average prevalence at around 15%. But depending on the specific study and the cohort of women tracked, the rate of POI has been documented as high as 54%.
Wait, pause on that. 54%. You're telling me that more than half of the women in those specific cohorts are permanently losing their fertility and their natural estrogen production before they even hit 40.
Yes.
How does that even become an accepted standard of care?
Because the alternative is death or permanent dialysis.
Mm.
The primary culprit here is cyclophosphamide, or CYC. It is a massive, heavy-hitting immunosuppressant. It's not handed out for joint pain or a minor skin rash. It is the ultimate rescue agent used exclusively for severe, life-threatening, organ-threatening lupus.
So how does a drug designed to suppress the immune system utterly destroy the ovaries? Let's go back to our firefighter analogy. Your house is burning down. That's the severe lupus attacking your kidneys, right?
Right.
The firefighter arrives with a massive high-pressure hose. They extinguish the fire. The house is standing. But the sheer volume and pressure of the water completely hollows out and ruins the home's foundation.
That's spot on. And biologically, the way that foundation is ruined is through DNA damage. Cyclophosphamide is an alkylating agent. Its entire job is to seek out rapidly dividing cells, bind to their DNA, and cross-link it so that the cell cannot replicate, forcing it into apoptosis or, cell death.
Right.
It does this to stop the rogue immune cells. But ovarian follicles are also highly active. The chemotherapy cannot tell the difference. It cross-links the DNA in the ovarian follicles, wiping out the ovarian reserve.
The sources show the risk goes up based on age and cumulative dose, which makes sense. Older patients already have fewer follicles in the bank, so it takes less of the drug to wipe out the account.
Exactly.
And once a patient is given over 10 grams of cyclophosphamide over the course of their treatment, the hazard ratio for permanent ovarian failure just goes off the charts.
It creates an agonizing dilemma for the patient and the clinician. And to add yet another layer of compounding complexity, the sources highlight a hidden biological multiplier.
Oh, the thyroid connection, right.
Yes. A clinical study of a Brazilian cohort found that 100% of the patients who developed cyclophosphamide-induced ovarian failure also presented with high TSH levels.
TSH being thyroid-stimulating hormone, which always trips people up high. TSH actually means an underactive thyroid, right?
Yeah, exactly. Think of the negative feedback loop. TSH is the brain screaming at the thyroid to produce hormones. If the thyroid gland is failing and not responding, the brain has to scream louder and louder. So a highly elevated TSH level indicates low, failing thyroid function.
Makes sense.
This study strongly suggests that an underlying, perhaps silent thyroid issue makes the ovaries significantly more vulnerable to the toxic, DNA-damaging effects of the chemotherapy.
This is exactly why we are mapping this clinical web. It's not a simple equation of lupus plus drug equals side effect. It's lupus plus drug, compounded by a silent thyroid condition, resulting in permanent ovarian failure.
This raises an important question. What is the true systemic cost of that ovarian failure? Because the loss of fertility is traumatic, absolutely.
Right.
But POI causes an immediate premature deficiency in estrogen. And estrogen is fundamentally protective for a woman's body.
Right. It's not just a reproductive hormone. It regulates massive physiological systems.
Exactly. When you plunge a woman into persistent estrogen deficiency a decade or more before natural menopause, you strip away cardiovascular and skeletal protection. Estrogen regulates osteoclasts, the cells that break down bone. Without it, bone loss massively accelerates, leading to early, severe osteoporosis.
Oh, wow.
Estrogen also maintains healthy lipid profiles and protects the endothelial lining of the blood vessels.
And lupus patients already have an intensely elevated risk for fragile bones and heart attacks. We just covered how lupus vasculitis literally burns through the endothelial lining of those exact same blood vessels.
So treatment-induced POI acts as a catastrophic threat multiplier. You are taking a patient whose vascular supply lines are already inflamed and narrowed by the disease, and you strip away the exact hormone designed to protect their heart and vessels. The biological cascade is profound.
So what does this all mean? We started this deep dive by saying we were going to meet the band, and it turns out this band is playing a symphony of compounding risks. If you want to understand lupus, you have to look at the entire biological stage.
You really do.
You can't just treat the joint inflammation while ignoring the cellular desiccation of secondary Sjogren's. You can't just treat the skin rash without monitoring the blood pressure for signs of the vasculitis grenade going off. And you absolutely cannot administer life-saving rescue drugs like cyclophosphamide without deeply weighing the systemic devastation of premature estrogen loss.
It proves that managing systemic autoimmune disease is essentially playing three-dimensional chess in the dark. Every single move, every new medication, every subtle symptom shifts the mechanics of the entire board.
It really does. But before we wrap up today, there was one detail buried in the sources that absolutely broke my brain, and we just have to talk about it.
Oh, I know what you're going to say.
Yeah. We just spent this entire time talking about the devastation of premature ovarian failure.
The ultimate paradox.
Yes. We know that estrogen generally stimulates the immune system. That's a biological fact. Historically, doctors always noted that lupus patients tended to naturally improve, clinically speaking, after they went through natural menopause because that estrogen stimulation finally dropped off.
The fuel was removed from the fire, so to speak.
Exactly. Well, one of the studies we reviewed tracked the specific women who suffered from cyclophosphamide-induced premature ovarian failure. Over a 5-year follow-up, those specific patients, the ones who lost their fertility and their estrogen to the chemo, presented with significantly lower lupus disease activity than the women whose ovaries survived the treatment.
It's wild. It challenges our entire definition of harm. The cyclophosphamide cross-links the DNA in the ovaries, destroying them. That triggers POI. The POI halts the production of estrogen, and without that estrogen constantly fueling the immune cascade, the primary disease, the lupus that was destroying the kidneys, is effectively starved of its key biological accelerant.
The devastating side effect of premature menopause secretly acts as a biological shield against the very disease the patient is fighting. It is just mind-bending. The chemo sledgehammer completely destroys the foundation of the house, but in doing so, it somehow fireproofs the walls against the lupus.
It forces us to ask, at what cost comes remission? When treating an intricate clinical web like systemic lupus erythematosus, sometimes the cure and the complication are indistinguishable. It is a profound, albeit unsettling, physiological reality to leave you with today.
It really is. Thank you so much for joining us on this deep dive. We've explored the cellular drought of Sjogren's, the explosive danger of small vessel vasculitis, and the paradoxical double-edged sword of our most powerful treatments. Keep questioning the mechanisms, keep exploring the connections, and remember that in the world of autoimmune disease, the lead singer might get all the spotlight, but the band is always playing in the dark. We'll catch you next time.